Thank you very much for inviting me. And it's a pity I'm not there with you. I'm in Rome with my mom. Here is very hot. I hope it's not that hot in Athens.
No, it is not.
It is a hot topic, though. The future of mitral interventions, I think, has been one of the first transcatheter interventions to be expected to be the game changer. Actually, that was not the case because the aorta came first at the end. But anyhow, I think I want to make it, a little bit practical. I think we are transitioning from a surgical approach where there was a wait and see approach, trying to postpone procedures. This was probably most the case in the past when there was a lot of replacement, but still today we are in that phase because of the invasiveness. With less invasive procedures, we go towards a model which is more intervention based on simpler procedures which are delivered earlier, trying to intercept the prognosis of the patient in an earlier stage. Obviously, this concept will have a success only if we reach enough evidence with randomized trials for early interventions. We need more devices, next generation devices, platforms, and also imaging is needed. And I'm sure that there will be a lot of novelty in this field, although we are not going to dismantle what we already have and is very solid, including TEER and surgery. Now, let me put this into perspective. My personal engagement with transcatheter business started in the early 2000s, probably late 90s. And at that time, the dream was just to deliver surgical treatments via a catheter. That was a dream, and actually the dream came true. Today, for instance, MTR is the most commonly performed mitral intervention to repair isolated mitral valve regurgitation in Western countries. Yeah, the crossover already happened a couple of years ago in most of European countries. But there is much more than TEER. There are multiple solutions, including repair, replacement, also hybrid solutions with half valves, and we will talk a bit about this later. So the landscape is progressing. And that is not only in terms of devices. We see better than before. So all this innovation in device therapy ignited the need for advanced imaging. We see now with echo, for instance, we almost have the same view of a surgeon, and even beyond that. We do more. We develop solutions which are so advanced and so close to surgical procedures, which is now called electrosurgery. We can interact with the anatomy, electrifying wires and making difficult things even more invasive somehow than the invasive surgery. But overall, we know more. I think that is probably the best legacy of transcatheter interventions in the past. We have been learning a lot from new devices, but we've been using also these devices to learn more about the pathologies we are treating. Still, there is a number of unmet needs, and I will not go through all this, but just to clarify that still, emerging therapies require new indications, new timing. We are learning about characterizing patients in a better way with imaging. So phenotyping patients is requiring a phenotype-specific treatment for many diseases. Transcatheter interventions are great, but there is still variability across the operator. We are still struggling in the mitral field for calcific disease. We still fail in managing patients with failed transcatheter procedures, and we still don't know about durability. In surgery, I think there is also something emerging, for sure, above all, in less invasive and even robotic therapies, but also the integration of artificial intelligence and virtual reality in surgery is going to change a little bit the way we deploy surgery today and in the future. In terms of medical therapy, we know that heart failure therapy is booming, and there are new solutions. There will be also new concepts in the future. one concept we need to develop is synergistic strategies between structural interventions and medical therapy, specifically for these patients. And finally, imaging. I see that around, I see Luigi Badano. The importance of imaging today is central. Everything we do is based on planning procedures, selecting patients, and modeling the outcomes using advanced imaging. So I think it's going to be a lot of need here to improve. However, let's go back again one moment, and I want to offer you my personal view. Being a surgeon who is also doing transcatheter procedures, I am confronted with the broad variety of solutions. And when I consult patients, I usually give this message. We love less invasive procedures, but honestly, the more invasive the procedure, the more we can predict the outcome. The outcome is more reproducible, it is more durable, and probably the efficacy is better. That has a cost in terms of risk, and obviously the risk of interventional procedure is much lower, but in terms of efficacy and durability, it's difficult to beat surgery. Now, and there is a linear correlation. Now, this linear correlation may be in the future solved and adjusted and mitigated by technology, including imaging, new generation devices, better planning modalities and digital twins, including co-piloting during procedures, and obviously materials, robotics, and all kind of novelty you can imagine will come in the next future. Let's go into what is available today and what is actually evolving. First of all, MTR continues to evolve. I told you it's the number one solution happening at the moment for isolated mitral valve regurgitation. Both Abbott and Edwards are continuously innovating. Generation 6 is going to come very soon from MitraClip, but also Pascal, a new device, will come soon. There are alternatives coming from Asia. One above all, I just mention Dragonfly, which is a device which is taking some inspiration from both MitraClip and Pascal and creating kind of a hybrid solution. But also, Merit from India is developing a clip device, a tier device. And again, some ideas come from different vendors, different industry partners. For instance, MyClip is very similar overall to MitraClip and Pascal somehow. MitraClip for the device, Pascal for the delivery. But they're coming probably soon with different sizes. So expanding opportunities and indications for treating more patients as we do today, and probably to improve maybe outcomes by emerging technologies. In the meanwhile, we also expanded our knowledge. And today, TEER is used in different indications. There are very interesting evolving indications. I would like to mention a couple of them for sure. In the setting of hypertrophic cardiomyopathy, and I've been involved in the last 3 years in congenital disease, treating patients with Fontan physiology. It's very useful for this kind of patients. So there are many new indications, but we need more. We can't treat all patients with TEER. I think there are other solutions. We love to see whether really transcatheter chordal replacement will become a real alternative. I think there is a strong surgical background on this concept. There are multiple companies working on that. Talking about the surgical heritage, I cannot discharge the idea of annuloplasty. For those who know me, there is a lot of criticism around Cardioband, but still we miss this technology. Annuloplasty is the most commonly performed repair procedure in surgery and is associated with extended outcomes. Now, annuloplasty is therefore needed, and I'm pretty sure there are some devices which will come to practice, hopefully more reproducible, simpler than Cardioband. I really miss this therapy in my practice. Annuloplasty also involves a single leaflet kind of function in surgery. So usually the posterior leaflet is immobilized by annuloplasty, and this concept is the fundament of this hemivalve replacement approach, where rather than replacing the full valve, some companies are working on just on the posterior leaflet to obtain similar outcomes, an intermediate outcome between repair and replacement. A very interesting concept still to be further developed. But above all, obviously, everybody is waiting for replacement. Replacement has a promise of being one size fits all. Every patient can be treated with replacement, and probably it is easier to learn and more reproducible outcomes. Interventional cardiology is based on reproducibility, and therefore replacement is expected. I'm not going to talk about replacement today because there are going to be a lot of discussions, and maybe you have seen already technologies. I just want to mention there is one enemy of replacement at the moment, actually one enemy of any transcatheter procedure, which is calcification. There is an emerging population of calcific valves, particularly the degenerative mitral stenosis is growing as a community. There are some initial outcomes using TMVR for calcific mitral valve stenosis. Both Tendyne and Cephia have been used in this setting, but there are also other opportunities around. Talking about calcific stenosis, there are technologies. In our practice, for instance, we expanded the possibilities of balloon commissurotomy using an echo-guided approach with stepwise approach. It's a completely different approach on balloon commissurotomy than in the past. We use this approach trying to reduce the risk of leaflet ruptures in complex anatomies, patients with no commissural fusion, patients with just calcification, and we obtain good palliation. We have been using also in some patients lithotripsy, using off-label shock wave 2 or 3 catheters. There are on the way solutions which are designed for this kind of therapy. But also in my practice, I see many patients where nothing works, and then we have to operate high-risk patients. And thanks God, thanks to the experience we got in transcatheter, I am translating this experience into surgery. For instance, the sealing cuff concept that is present in most of these transcatheter valves can be also used in surgery, creating a kind of a fake artifact sealing cuff. You can see here the sealing cuff taking care of a PV leak. Surgery remains central in degenerative MR in younger patients with long life expectancy, and surgery is not anymore an invasive procedure. Most of our procedures are done endoscopically, sometimes with robots, and I think there will be more and more robots in the future. Surgery is associated with very long-term outcomes and durability, so it is difficult to challenge this kind of data. Procedures are very low risk and patients recover very early. Today, it is the best solution for younger patients, but we live in the era of modernity, and I'm not sure that this is going to be the case forever. And I want to also just conclude talking about AI. We are in the era of coexistence between man and machine, and AI is expanding in all areas, starting from imaging. It's not new. We have fusion imaging and other technologies using AI, improving AI planning and automatizations. Mixed reality and holograms are becoming more and more available. I think holographic imaging could be very important in the future to simplify delivery of procedures using robotic and holographic visualization of structures, real 3D images. We have been, since many years, involved in augmented or mixed reality. This is how we have been using, for instance, for complex aortic valve. This is a patient with a very large annulus where we had to go subclavian for a pure AI with less calcifications using a large device. And overall, AI is everywhere. So I don't want to talk too much about AI. It's not my topic, but AI is going to be embedded and is going to enable automatizations. There has been already some experience in automated procedures for TAVI, but in future will be also for mitral, because robotics, both in surgery and interventions, is going to be very important. I really believe that robots is the future, but for one single reason, not because I need as a human being or as a surgeon, I don't need a robot. I learn how to work without robots, but our experience is something different. I think Carpentier already got this idea that there will be a robot in the future to treat patients. He made a mistake in this prediction because actually the era of robotics came much earlier. And he also said that in 2050, you would treat patients immediately in case of chordal rupture, replacing the chorda, just like you replace you correct a broken bone immediately when somebody has a fracture. So all this is happening. And it's happening more than that. We have telepresence. We can use robotics to support and proctor procedures to minimize the difference between different operators, to learn, to teach, to expand indications, to create an environment of better and better care. We have been involved in automated TEER robotics. This is a tool which is actually performing a procedure independent from a human being. We have been teaching this machine by observing our movements, and now we have a machine that potentially could do a TEER procedure without a human being. This will not be, though, the future. The human will be always in the middle. So at the end of this, 25 years and looking at the future, I still believe that there is a role for surgery in DMR, no discussion, but this will be more and more assisted by technology. More and more AI will be embedded in surgery, and there will be surgery which will take some advantage from the experience we got in the transcatheter procedures. In secondary MR, planning, profiling, digital twins, and everything is going to change everything. We need to integrate artificial intelligence, biomarkers, advanced imaging strategies to intercept the patients earlier in the best moment. But we also need to build a community that is able to integrate strategies between devices and medical therapy. And we need to build this community based on the concept that the more granular we get, the more doubts arise. This is actually my personal experience and the fear or the opportunity for the future. We have a lot of opportunities. We have a lot of options, but still we need to be able to open our mind and be ready for change and be ready to assess and check that the change really matters. So for this reason, for those who don't have much to do and have a little bit of time spared, I really suggest to have a look at what I wrote on the European Journal of Cardiothoracic Surgery about doubts in the words of certainties. I think the more we go forward, the more we need to doubt our certainties. Medicine is completely changing. The future is going to be much better than the past as usual. And we need to embrace the future and the opportunities that are coming. With this, thank you so much for your attention, and I'm pretty happy to entertain any discussion.
So, Francesco, thank you so much. It was an amazing presentation, and I'm sure that you studied the ancient Greek philosophy because this is Socratic, right? So, it's a Socratic saying. So, as far, as I grow up and learn more, so maybe I don't know nothing at all. So this is very important. So I'm flagged with two renowned Greek doctors, Dr. Kofidis, a renowned surgeon, and Dr. Athanasopoulos, a special imager and echocardiographer. So Francesco, you suggested that with AI, you might have the tools to help us guide through this mitral procedures. Do you think right now, or maybe in the near future, can guide us, can help us identify the proper patients to do these procedures before clinical deterioration happens? Because we always say that we have this MR patient that now it's better to treat conservatively, but very quickly we have a deterioration, and maybe at that time it's too late. Do you think that AI might be even now a good clinical tool to identify these patients?
There are already some early reports on using AI for profiling and predicting patient outcomes. So I'm not sure we are ready for that. AI is just at the beginning of its career in medicine. At the moment, AI is mainly used in early detection of any kind of disease, not only cardiovascular. I think that is where it's already playing a role. I think radiology is absolutely potentially. I don't think we need a radiologist in the future. In terms of predicting the trajectory of a patient with multiple factors and multiple comorbidities, and multiple key elements for the final outcome, I don't think AI is still ready. AI is nothing else than anyone who has a career in a field. We need to educate AI. We need to build AI. We need to give AI the right data. So as usual, garbage in, garbage out. So we should not expect too much from AI, but AI will be a support for physicians who are willing to expand their knowledge. And we are working on AI with AI just to boost our potential knowledge and utilize advanced models to try to help us. At the moment, there is no AI. There is not artificial intelligence. At the moment, we need to use human intelligence to identify the sweet spot for therapies and what is the best therapy. But I'm sure the more we get into this field, the more support will come from technology.
Okay, good. So any other comments from the audience, Dr. Kofidis?
Francesco. Hi, good to see you, Francesco. Always good to see you. Thanks. Looking forward, yes, I believe AI will play an important role, but will doctors respect whatever AI suggests then? First of all, you know that for machine learning or AI, we need huge calibration populations, right? Like thousands of patients. Let's say AI says surgery. Will the cardiologists across the world send the patient for surgery? It's going to be restrictive. Or the opposite. It says mitral clip. I think that we have consensus. We must have consensus amongst colleagues. There has to be a proper heart team that addresses these cases, and I see much more benefit coming out of this than any technology. If AI is to be implemented, then it has to be implemented. I operated a patient last week, 71 years old, torn mitral clip, hospitalizations in and out with a severe mitral valve regurgitation. I'm glad that we have a team, surgeon is there, we managed to fix it, but unnecessary evil, you see. So your thoughts on that? Will it be implemented?
So Theo, I mean, that is a very philosophical question. We are now in the era where we say human in the loop. Okay, that is the topic. Whenever you talk about AI, there is always this phrase, human in the loop. How long the human will be in the loop, I hope forever, but I'm not sure that humans are superior to models which are fed by reliable data. I think at this moment, we should not overemphasize AI. We should not overexpect from AI. AI is at the beginning. We are just, it's just like, imagine it's like echocardiographic imaging in the 80s, okay? Something that you see fuzzy images. Maybe at that time, stethoscope was better. So we should use our own practice. We should not become technologically attracted by technology without criticism. But at the same time, the society is losing their ability to use their criticism. We are surrounded by AI, and my fear is the next generation will be less able than we have been able to have a critical approach and a cognitive approach and an empathic approach to our profession, which will be the reason why in the future maybe FDA will be forced to allow a machine to take the final decision, because maybe in the future there will be no humans to take able to take a final decision. So, I mean, that is obviously a tremendous vision. I hope it's not going to happen. But if we want that this doesn't happen, then it's true what you said. We need community. We need hard team. We need to keep communicating among us. But at the same time, in this hard team, I see the value of having a model, let's say having a Claude in the room, and ask Claude, what would you suggest, and start from there, rather than having the question given to any of us, because we have more biases than probably any AI at the moment.
Yeah, that's a very good answer. Thanks, Francesco.
It was a great pleasure to have a lecture from you. I will put a very practical example from my experience, from my teaching experience. Quite often, when somebody wants to understand the severity of an aortic regurgitation, we see that there is a requirement for MRI. And the doctors ignore that the pulse pressure is a key component to justify the presence of severity of AR. This is a very, very simple example that nowadays the massive production of information without a proper critical pathophysiological understanding has become the real-time problem we face, at least in our clinical practice. I believe that currently these massive comments upon AI have distorted the ultimate aim of medical education. Currently, the colleagues, the new colleagues, the fellows, are searching the ChatGPT for answers. And they don't pay the proper attention to study in depth pathophysiology, pharmacology, nosology. I think this phenomenon is obvious nowadays in clinical practice for handling of valve diseases. There is this problem of understanding how to make the proper decision to intervene or what to do in valve disease currently. This is the phenomenon which has to be understood and properly handled by the academic environment and the teachers.
Okay.
Great point.
Yeah. Thank you, Francesco. So before closing, do you have one? If you could share one practical rule for the audience on how to properly select mitral valve patients for whichever treatment, what would that be? One practical rule.
Okay, let me just in a few seconds tell you how do I do my practice. Again, I am a heart team embedded in one person. Okay, so in principle, I bring with me every day the doubt of what is best for any individual patient. So the way I take a decision is a three-step way. I use three tools, and they are all three tools are clinical tools, or let's say medical devices. The first tool is knowledge, clinical evidence. What is written in the papers, what is written in the guidelines, what is the evidence from RCTs, what do we know about durability of any procedure, risk benefit, whatever you want to put in your bucket for decision. So data, let's say knowledge. The second level, the second tool is the technology, or let's say the feasibility. What is feasible? Not everything is feasible in every patient. So in some patients, the anatomy will not be feasible for TAVR, for TEER. In some other patient, there will be some challenge for surgery, whatever. So there is a technical limitation. And whenever you have different options, you usually should choose the option which is more reproducible, simpler, and safer for the patient. At the end of these two stages, which is knowledge and technical, I still have a lot of doubts. And the third medical device that I use is empathy. And empathy is not a sentiment. It is a device because it helps you to take the final decision. How do we take decisions when there are 2 or 3 options available and all of them are okay to some extent according to data, guidelines, and whatever? Well, the only way is to enter into the mind of the patient, get empathic with the patient, have a bidirectional sharing of knowledge. You need to know the expectation, the lifestyle, what is the current status, what are the fears, what are the objectives of this individual person. So only once you transfer all your knowledge, all your doubts to the patient, then both of us, me and the patient, we find the solution that appears to be the best at that moment. So that is the reason why I call empathy a medical device, because it is the final tool to take the final decision.
Excellent, Francesco, as always. So, and philosophical as well. So thank you very much for that. We have to leave it there. Have a great weekend, and we'll see each other soon. So, okay.
Ciao. Ciao.